All right, we're live, everyone. Good morning, everyone. Thank you for taking time to be here today. We are very excited to share with you the Community Engage 2022 Summer Webinars and Journal Club. My name is Daniel, and I'm convener of the interest group. I just want to highlight to everyone that we have coming up a webinar on low-income contexts on June 13. To sign up, just go to geron.org/webinar. We'll be hearing from a few wonderful people who've been working among refugees and among homeless populations. And we also have a series of journal clubs coming up talking about research participation, collaboration, and implementation in CNR. And in addition to that, if you're interested to signing up for all these journal clubs and you want to know more and you want to build relationships, please drop me an email at drgan.sfu at sfu.ca. That's drgan@sfu.ca, and we will invite you to a peer mentoring space happening an hour before this journal clubs. The peer mentoring space will be facilitated by Dr. Sarah Des and Professor Patricia Slatham. And without further ado, please allow me to introduce us to our moderator today. Today we are very happy and glad to have my wonderful colleague, Dr. Mariko Sakamoto, who is a nurse and a postdoctoral fellow at the Center for Research in Personhood in Dementia at the University of British Columbia. Dr. Mariko does excellent work in the area of flipping stigma and participatory action research. I will hand this time to Dr. Mariko. Mariko, please.
Thanks, Daniel. Good morning, everyone. So happy to be here. Thank you for that lovely introduction, Daniel. As he mentioned, I am from Vancouver, BC, and it's an important practice that we have here in Canada is a land acknowledgement before we begin any type of session together. And as these sessions are about engaging with communities, I really think this is a great way to start and an important way to start. So I'm going to situate myself in terms of where I find myself today, my community, my city. So I'm going to start by saying that I'm very grateful to acknowledge that I live, learn, and play, and am an uninvited guest on the unceded, traditional, and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And I invite all of you, if you wish, to share where your community location is and the lands you're on in the chat. So having said that, let's talk about community. Today, we're going to be hearing from two speakers about dementia prevention. And as we know, primary, secondary, tertiary prevention occurs in the community setting, but communities aren't homogeneous entities, are they? Communities have varying social cultural needs. They have different organizational resources. So this is what we're going to be focusing on today. And I'm very pleased to introduce our two speakers. We have Dr. Patricia Hein, professor at the School of Health Sciences at Marymount University. She's going to be talking about dementia prevention from a clinical perspective and focusing on the Kickstart, Assess, Evaluate, and Refer Toolkit. She'll be beginning our presentation, but I'd also like to introduce our second speaker, Dr. Jordan Lewis, who's a professor of family medicine and biobehavioral health at the University of Minnesota. And his presentation will focus on community-based participatory research to improve access to dementia care for Indigenous populations. So we have two very interesting perspectives today to explore. I invite you to include comments and questions in the chat as we go along, but we're going to have time to all discuss together afterwards. So I'm going to turn it over to you, Patricia.
Okay, thank you so much. I'm so excited to be here today. Thank you for inviting me. I'm going to be presenting a tool that has been developed by the Gerontological Society of America, which I have been the pleasure to be involved at some point, and that's what I'm going to be introducing today. So let me go ahead and share my slides and see if I can work that. Okay, just a second. Okay, can you see it?
No, we don't quite see it yet, Patricia. There we go. Yeah, we see it now. Thank you.
Okay, great. Already. So if you're not familiar with the KAER tool, I will strongly suggest you to visit the Gerontological Society of America, the website. One of the pages from the GSA has the tool available. It's public, it's free. It's a great tool that has all the steps in how to use it with the populations in terms of screening, in terms of starting some of those conversations, using different settings, and as well as with care partners. I couldn't go on without acknowledging the developers of the tool. Also, Ms. Karen Tracy at the GSA, who has been the champion and the person involving the initiative and really making sure that the tool grows and keep being redeveloped and redesigned. Also, I would like to recognize the original work group members. There was Dr. Richard Fortinsky, Katie Maslow, Dr. Fred Kobilars, and Mr. Jan Kramer. I was part of the new reviewers for the revised tool with many other investigators. So the objectives of today is for us to look into this tool as a potential community tool that could engage care partners and also other organizations in the community to proactively use the tool or adapt the tool into their systems to take care of our older adults. Also is to do a brief overview of the tool and explain the 4 care processes, and then discuss about some of the areas that we have been not exploring in terms of the tool implementation and adaptation. So the tool was developed with the support and also with many initiatives that call the attention for brain health early detection, helping community and clinical professionals to use approaches that they can integrate into their practices and include referrals and better treatments as well. So by saying that, the tool has been developed for some time now. It started in 2015 with a work group from GSA. And as I mentioned, you saw some of the early developers and the champions with the tool, and they has been growing and taking more of national representation and also more support in terms of funding and other areas of expansion that we would love to hear as GSA keeps presenting and keeps generating those workshops related to the new expansions of the tool. So its framework, it is based on 4 main concepts that I'm going to be showing, but it is to involve the care partners, give an opportunity for the person into the process, especially since the focus is to start there early before the disease is developed in the brain, and help and support into the development, possible even intervention, and some approaches that can enhance the quality of life and keep the person aging in place, as well as functional within their own environment and the community. So the tool is based, the KAER, these are all the different stages and implementation of the tool. So the first one, what we call the K, is the Kickstart of the tool, and then I have this is a better view of the different stages. That's when you start the conversation with the partner, with the person and the family, or the care team involved in the care of the person. And then after the conversation, when you do already an evaluation, if it's needed, you go and do the assessment using some of those well-established evidence-based cognitive screenings that we're going to be showing here today. And then you evaluate for the symptoms as further referral or potential of other factors being involved, such as depression, or could be other conditions that could be masking and not being the case for potential cognitive decline. So the desired outcomes, it is to start the process early to create a supportive environment and increase the quality of life of the person and the care partners. So the tool has several components. It does assess some other areas of potential impairment. It has been expanded to more sensory, and aside from just the cognitive domains, but it has been including other areas. And right now is under more study and being under evaluation for more redesign. So it's almost like we keep evaluating and keep adjusting and calibrating the tool as we learn more, which is so important because this process is so dynamic, it's not static. So it's important to have those tools and approaches that can support that current development. And that's what we're going to be talking more today. So it is based on including validated instruments and instruments that can be rapidly used by most of the persons involved in the care, including the care partners. Also encourage that the conversation that is so difficult, like I see with my own parents, every time I talk about, did you do your cognitive assessment? Did you talk to your physician? There's always that barrier where they don't feel comfortable and they don't want to talk about that. And so it's important, like if we cannot directly talk to our loved ones about brain health, at least we can bring that into the treatment with their primary care physician and start to have some of those conversations early. So some of the cognitive tests are the mini-cog and the GP-cog, the memory impairment screening, and those are all very described into the tool, and there is lots of information and background and the evidence that support those tests. There's also those family questionnaires or the care partners as the AD8, that is an informant interview, or the GP-cog that also acts as an informant tool, and some other ones. This is just to give you an idea of how those tools that were selected supposed to be short and practical. So this is the AD8, where you can evaluate the family and the care partners and start a conversation. And so it's a very guided and systematic approach to start the process and then to have an evaluation. So many times we need more than one simple cognitive screening, and so it's always good to validate it with a second one. Many of my participants, they come to my cognitive screening already pre-prepared. Nowadays, you can find many of those cognitive screenings available in the internet. So I have people that the family come and they disclose that the person was training the test before coming to the evaluation. So it's always good to have a plan B and to validate some of those results with additional testing. So this is one that I have been using as a second validation, these lumps. So if you're not familiar with that test, I feel like it doesn't have some cultural sensitivity, but it does help in terms of being a validated, a confirmatory tool. So it's important to differentiate between detection, screening, and diagnosis. For no means the tool or any of the approaches in the tool are to have a diagnostic outcome. As I mentioned, is a starting process, is to initiate that process of brain health, of care. So it's really mostly based what we call those screening tools that could help in terms of early detection and referral, and to expand on that. So it's more than just using the tool and looking at the results, but actually like how now we can use that screening tool in a more meaningful, in a more pragmatic way. And that's really, I think, what is the impact of the tool. Also, we have to be careful about always thinking that it could be some other symptoms, some other conditions, having a real conversation with the family about the process and the events. When some of those symptoms start like to be more prevalent, significant, and looking at possible other causes is really, really important. And the tool also helps for that. The tool comes with also referral, some recommendations, which is very nice, and how to help, even though it's a screening tool, but it's so important, like if someone is going to be in a health fair and some of those instruments might be into that cognitive screening, there's no really like a path to referral. So it's important to not to scare the person, but to call the attention that they might need to talk to their primary care physician about some of those issues if they think like the person has been consistently showing some of those symptoms. So again, very important that our tools that have such a large implementation are informed by research and have the ability to be flexible, not only the resilience to be sustainable through time, but also to change through time as we learn more from our research. So by saying that, I'm gonna finalize my presentation introduction to the tool. And also I would like to again acknowledge some of our early innovators and the creators of the tool. And I hope that we have, like Katie Maslow is present today, and Tracy, and I would love to acknowledge them and ask them if they have anything to add before we start our discussion. Katie, are you attending the webinar?
Can you hear me?
Yes.
So Patricia, you did a wonderful job. Thank you so much. I think that one of the things about this KAER toolkit that you didn't stress, but that I think is important for researchers and clinicians, is that it includes, sometimes in one version, just write in the toolkit, and in the other version, you have to click on it, but it includes the short assessment instruments so that clinicians can look at the different choices and see what they're comfortable using. And then many of the other tools are also present in the toolkit. And I think that's useful for clinicians who sometimes hear the name of a tool, but they don't know what it actually asks or looks at. So thank you for your report, though. It was great.
No, we want you to be in the discussion, as now we're going to be talking about some other ways to implement the tool. But also I want to highlight what you said is so important. Like there is also instructional videos on YouTube, how to, for interview, how to properly do an ethical and very sensitive interview, because it's always so a scary moment for the family and for the person when you start to talk about brain health and potential diseases that might impact your brain. So it's very nice that there is supplementary material and videos that guide you how to start the conversation in a very sensitive way and very respectful. Okay, I will pass now to Mariko to help us to guide the discussion.
Oh, thanks, Patricia. Thank you for that presentation. I think what we might actually do is hear from Jordan first, and then we'll have a cross discussion, if you will, if that's okay with you, because I think we're going to have a lot to talk about in terms of the possibilities of this toolkit and also how we can engage in communities with this toolkit. So thanks again. Patricia, I just want to bring your attention. There are some questions in the Q&A, so I don't know if you want to have a look and type those in, or we can leave them for the discussion afterwards. But having said that, folks who are here, please do continue to put your questions in there and we'll certainly address them afterwards. So what I'll do now is I'll pass it over to you, Jordan. Please go ahead.
Can everyone see that all right?
Yeah, looks great.
Thank you. Well, it's an honor to be here. Thank you. I'm excited to share some of the work we do at our center. I'll introduce myself a little more. My name is Jordan Lewis, as mentioned. I'm the Aleut from the Native Village of Naknek in Southwest Alaska. I'm currently the Associate Director of Memory Keepers Medical Discovery Team, which is with the University of Minnesota Medical School Duluth campus, and also a professor in the Department of Family Medicine and Biobehavioral Health. This presentation really is focused on the work we've been doing with our team here and looking at the importance of engaging communities throughout the process, more of a research-focused process, looking at what the importance of getting a cultural understanding of dementia is for prevention of dementia. So to start off with, why is this work important? There's a lot of challenges to accessing dementia care, accessing, providers to get a diagnosis. And some of these, stem from some of these common things we hear that many medical providers are uncomfortable with giving a diagnosis. And this could be their lack of understanding of cultural conceptions of dementia. There's still this idea that, for some older adults, they dismiss dementia as it's just old age. There's nothing wrong with me. There's nothing wrong with my grandma. And for our providers, the reasons they give us, that we've learned in our research is there's not enough time. Our providers are very busy. A lack of training around dementia from different cultural contexts. And they may not be, due to the lack of training, not comfortable with making that diagnosis or having those conversations with families once that diagnosis is made. And so we're seeing that many of our primary care providers are referring to specialists, which is fine, but we need to increase the amount or the availability of diagnosis across the healthcare spectrum, including our providers and social service agencies. Other challenges we're learning about is, they're within our tribal communities or our Indigenous communities, we're competing for funding, they're competing for support from the government and other sources. And so there's other priorities. As dementia is growing, though, we're noticing more effort put in that area, but they're competing for funding when it comes to substance use, substance misuse, diabetes. Right now we're noticing, the past 2 years, COVID-19 has really been a focus. And looking at health of the youth, health of our families. And so as we think about how do we help communities recognize this need and help them reallocate those resources as necessary, as more communities are noticing changes in their family members with regard to cognitive health, we are seeing some communities shifting that priority to dementia and wanting to learn more and find out what's going on. So to address this, the most important part is, the work that's being done, the community members who are going to be impacted should be part of that process. And so in our center, Memory Keepers Medical Discovery Team, we're really big supporters and we adhere to the community-based participatory research principles. And this is a commitment where, the communities we partner with are equal partners throughout the entire research process, from finding out what the priorities are for the research project, all the way through dissemination, community reports, presentations, and our community members are engaged and with the goal of having a benefit with the result of action. Our ultimate goal is that it would be scalable across diverse communities. So what are things we're learning today that could be used in other Indigenous populations or other racial and ethnic minority communities, as well as rural. And then we have a commitment to capacity building and sustainability in our communities. I'll give some more examples of what this looks like, but working in the community, having community-based researchers, all of this really enhances local expertise, the training and education beyond what we do as a center. So this is our upstairs floor to give some idea of our center. We're located in downtown Duluth. Our mission is that we're focused on health equity for rural and Indigenous populations in Minnesota, with some study sites in Wisconsin and Canada. And we emphasize healthy brain aging. We really use a team science approach to our work, very interdisciplinary. We have a very full team. I think we have 20 staff right now. We have 3 faculty, and we're working in partnership with communities using that CBPR framework, always approaching our work from a strength-based approach, and then using a two-eyed seeing approach, which I'll talk about. So two-eyed seeing in Indigenous knowledge, the Mi'kmaq elder Albert Marshall explains that two-eyed seeing is a gift where we learn to see from one eye with the strengths of Indigenous knowledge and Indigenous ways of knowing, from the other eye with the strengths of Western knowledge and Western ways of knowing. And they're looking at addressing that power imbalance that exists between those knowledge systems and placing equal value on Indigenous knowledge with Western knowledge. So one of our centers, so a bulk of our work has focused on Indigenous communities here in Minnesota and other areas, as I had mentioned. We also have a rural focus, and a bulk of our focus is also developing CERR, which is our Center for Community Engaged Rural Dementia and Alzheimer's Disease Research. And this is really an exciting time. We're in the process of partnering with rural communities. I know we have a few of our team members on this webinar today, and looking at where we have just launched a rural dementia research registry, and we're using that to recruit and communicate with participants. And the goal of this is to establish pilot data, get some work going to continue to get funding and work on a center grant through NIH in building our infrastructure in rural communities. So to give you some idea of how we do our work, all of our projects are community-based. We establish community advisory councils in each of the communities we work with. That could be representatives of people with dementia, could be caregivers, tribal council leaders, family members, community members. In most of our projects, also we hire community-based researchers. It's really important for us to have that local knowledge throughout the entire research process. These are people that are from the communities that we're working in, very familiar with the culture, the context, the relationships that are so important to ensure this research is successful, but also representative of the community. Part of our expansion of our centers downstairs, we've now expanded not only office space, but we put in a CBPR training lab. When we get to that stage, we'll be bringing people in for research training, for conferences, for community engagement projects. And so that's still in the development phases of what that's going to look like. But we have some really exciting ideas that we're getting from our communities. As I had mentioned, our community members are equal partners. We also have a community engagement specialist hired as part of our team, a very knowledgeable individual who is American Indian from Red Lake Nation, very well connected across the state, who helps us establish those relationships with communities. And then guiding our entire center, we have 2 advisory committees. We have one that's consistent of 11 Indigenous elders, representative of the 11 tribal nations in Minnesota. And then we have a rural advisory committee that helps oversee and guide our rural work. This is some pictures of our expanded downstairs in our community-based participatory research lab in one of our conference rooms. They're all Zoom capable. So we've been able to keep our community-based researchers connected to our work through Zoom and attend meetings and staff events. So some examples about some of our work. Our executive director, Dr. Kristen Jacqueline, has done some amazing work in Canada. And so she's started the Indigenous Cognition and Aging Awareness Research Exchange. If you want to go to this website, excellent resources. They adapted the KICA, which was originally from Australia. She adapted it for the Canadian Indigenous Cognitive Assessment. And it was with a community-based research team with Anishinaabe groups, Manitoulin Island Advisory Council members. And so there is on this website, there's videos on how to use the materials. I believe they're in both languages, English and the Indigenous language of the communities. So it's an excellent resource for people who'd like to look at that. Also on this website, there's other resources. There's also the Indigenous Dementia Research Network, which is a great group to kind of learn about what's going on globally around Indigenous dementia research. On this website, these are just some examples of fact sheets that have been developed in partnership with the communities Dr. Jacqueline and her team have partnered with. And so these are available on that website. You can read through them. They're available for downloading, but really great examples of working with community partners to translate what they're learning about dementia research into community-friendly or accessible materials that everyone can access and understand. The Canadian Indigenous Cognitive Assessment, adaptation to validation, this now has been expanded. They're in the process now. They are looking at developing it for an American Indigenous Cognitive Assessment, AMICA. And so that will be looking at adapting the same cognitive assessment for Indigenous populations here in the United States, which is really exciting. So here's some more examples of what the KICA tools are on another website. So you can see the videos here on the left. You can watch those, kind of get an understanding of what the assessments look like, both in English and Ojibwe, also in sign language. And on the right here, you can see the actual materials. So there's supplemental materials that go with it, instructions on how to use the KICA, a culturally safe guide to using it, the tools both in English and Anishinaabe, and then drawings. So I know it's a really quick overview, but really wanted to emphasize the importance of engaging communities to really establish that foundation of cultural understandings of dementia in order to start exploring and developing tools to address prevention and supporting caregivers and families who are facing the challenges, but also the blessings that our caregivers talk about when it comes to people with dementia. Thank you.
Thank you so much, Jordan. Really great to see what's being done in Minnesota. So we're going to open it up now to discussion. And as we do so, I just want to address some of the questions that have come up in the chat and the Q&A panel as well. And maybe we'll start with you, Jordan, because there was a question from Shannon Freeman, one of our participants today. And she's just wondering what sites in Canada that your team is working in partnership with.
So I don't know the specific names of the communities, but I know they're on Manitoulin Island. And I think that website will give you more specific names if the communities decide to divulge that, but that would be Manitoulin Island is the answer.
Okay, thank you. I'm interested to explore, and I think we'll address some of the other questions as we do this. When we think about a toolkit, so if we think about, Patricia, your presentation and the KAER toolkit, we had some questions in the chat about these ideas of community and how you determine stakeholders and how you connect with them. Sylvia Sorensen in the question in A asked how the toolkit is informed by community members. And Patricia, you'd mentioned that Katie might be the best person to answer that, but why don't I turn it over to you first to kind of get that part of the discussion going, and then Jordan, maybe we'll have you come in afterwards.
Mm-hmm. Yes, definitely. So as I mentioned, the tool has been under development since 2015, and it has been under revision, and the most recent revision was in 2020. So every time that I was involved into the process, there were, especially at the annual meeting, there were like special dedicated sessions that were by invitation, and then we had several representatives from different areas that were into the room and talking about, the tool and the experience and some of the implementation and the challenges, and some discussions about moving forward and improvements to the tool. And aside from that, also I would like to acknowledge Mr. Jan Creamer, who is a huge advocate, and he worked with so many groups on protecting and making sure that individuals with Alzheimer's are treated in our society with the most respect and ethical considerations. And so he also is extremely active in advocacy, and so he also was involved in the development. And so I'm sure that there was a very lengthy and rich process in developing the tool in a way that it is today. But Katie, I don't want to take your words, and you really have been a champion and a creator into this tool development. So I really would like to for you to take the podium and tell us about the early developments and all the wonderful work you did.
Thank you. Can you hear me okay? So when we started this, as you said, we had a group together that was researchers, clinicians, experts, answering the question, what instruments should be used to screen for or for that early detection of cognitive impairment and dementia? So that was 2014, 2015. I would say that we did not involve diverse communities in this. It was a first, and it was not the primary focus here. So there are some sites that are now using KAER and adapting it. I saw recently there's a Korean adaptation going on at NYU. I think that that's totally necessary. And then I would just say, I don't know how much all of you are aware of or involved in at the national level, an extremely strong push now to pay attention to diverse, underserved communities. And so I have recently talked with Jordan about trying to find researchers who are now required to have stakeholders from the relevant communities on their research team or advising their research team. So these groups are desperate to have individuals who can clarify. And Patricia, with what you said and what Jordan said, how to communicate these kinds of questions, how to make people feel comfortable to speak with their physician or a nurse about these issues, which are very stigmatized in the society as a whole, but especially in some groups. So Sylvia, your question is great. We're working on it a little bit, but very interested in having any assistance with that. If anybody would like to talk to me more about it, I'm glad to do that. Karen Tracy is the person, as Patricia said, who is at GSA and is updating. I'm a visiting scholar at GSA, so I am paying a lot of attention to this and also to these stakeholder issues.
And yeah, Katie, you just remind me, like when I was talking to GSA and was Judith and Karen, they needed someone to translate the tool into Portuguese. So I volunteered to do that. So now you just remind me I need to follow up with my volunteering promises, which is so important. I will say for my family in São Paulo, which my dad now is starting the early stages of dementia, they have not been able to talk to a physician about his brain. It's always the cholesterol, it's always the other general health issues, but my brother has been extremely frustrated about the lack of skills from the profession. And I'm talking about São Paulo, which is one of the most high economic city from Brazil. So I cannot even imagine outside from São Paulo how that is even more needed and underserved. So definitely we need the tool to be translated into other languages, especially to those countries where they're really lacking and running behind with those conversations, with referral and starting early the process, not when the person is already so advanced that it gets very challenging to start with the right treatment.
Yeah, thanks, Patricia, and thanks, Katie, for adding that your insights. That was really helpful to hear what's what considerations are in place at this point. Jordan, could I bring you in here to see what you might have to say about that? Because translating a tool is important for sure to be able to reach different groups of people. But what else needs to be done in terms of reaching out to communities?
I think so. The first thing that comes to mind is building that trust. I think depending on many of our communities have a negative history with healthcare or a variety of other groups, I guess. And so working in the communities we're in, the importance of building that trust and rapport and building those relationships are key to having these conversations of, okay, now that we realize that dementia is a concern in your community, I think now the process is once we start understanding what it is, from a cultural understanding or community context, it's having those conversations of, okay, well, to really help communities and better understand is that how do you get to that clinical conversation? Okay, now you've done the assessment, or, there's biomarker research coming out now that's so important that has such big implications for communities and people with dementia, as well as their care partners. I think that we're in the process of how do you broach those conversations in a way that they don't instantly shut down because of past medical abuses or bad interactions with their healthcare providers. And so how do you have these conversations where you can take the researchy part of what we do and put it in context of, is it more framing it of you're helping the future 7 generations, or you're doing this for your grandkids, or this is important because maybe in the future your grandkids won't have to worry about this. Those conversations should really be, and how those conversations are directed should come from the community. So that might not be appropriate in all communities. The communities I've worked with, definitely they've said, to be more effective, to help us think about this work, put it in the context of, it's not for me, I'm not doing this because I want to be healthier, that's a benefit. But if my grandkids don't have to worry about dementia when they're older, then I see the value in that. And I think, as Katie and Patricia have talked about, having a broad range of providers and specialists, whether it's community members, neurologists, nurses, community health aides, family members at the table to adapt these surveys, I think makes it much more culturally appropriate, but also communities will have more buy-in when they know that a wide range of people are part of that process and not just the select few or just the researchers.
Yeah, thank you so much for explaining that and really demonstrating that it is a process of building relationships, and that takes time. Because I think there's always the risk of trying to involve people, but doing it in a way that's tokenistic. And perhaps this is a good way to kind of segue to a question I see here in the chat from Ted Ing. He's asking you, Jordan, to share some tips for and lessons learned about community-based participatory research approaches. Because I think there's something there about building relationships, isn't there? About reaching out and doing that work that's necessary to build that trust.
Yeah, thank you, Ted. That's a great question. So we've actually written a publication on how mistakes we've made doing community-based research and the lessons learned by doing it wrong. which you don't see very often because I know a lot of publications and grant work that it's going to go flawlessly. But some of my tips I would recommend to, any researchers, whether you're a senior researcher or brand new, is to spend time in the community, not as a researcher. I think it's so important for people to see that you're invested in getting to know the community. A lot of the work I do in Alaska, that involves going to basketball games, asking people who are some of the elders in the community I should visit. Not that you need to know them really well, but express interest in wanting to know the community outside of just there to collect data. And they'll, if you ask your communities, and the way we've learned is community members will say, I wish you would stay longer. There's a basketball tournament this weekend. It would be really fun for you to go and see our kids play. And so that's what we've learned, is adding that time into your research process to just be a community member. Other tips is that, be flexible. It never goes always as planned, whether it's weather related, whether it's IRB related. Working in a lot of communities, sometimes leadership changes. And the new leadership may have no idea what your project's about. So restarting that conversation over. The other tips would be, we don't make promises you can't keep. Don't overpromise something. Community members will remember what you said you're going to do. And the last one would be not constant communication, but keep them updated on what's going on. Even if there's not much going on, just kind of check in and say, this is what we're working on. Do you have any questions? And kind of keep them in the loop. So then they feel more engaged and invested in what's happening and not left in the dark until, oh, here's a publication we want you to review. Those would be the top that I could think of.
Yeah, great tips. Thanks so much. Love to read that publication that you're talking about. I don't know if you can just like pop the name of it in the chat so that we could all look it up. But hearing what you're saying really makes me realize that it's much more than just having an advisor group, for example. It's an entire process that takes investment and authenticity. Patricia, I'd be curious to hear your thoughts in terms of how this discussion is going and possibilities for the toolkit, especially when we think about making those connections to different groups.
Yeah, and I have a vision. So I think this toolkit is such a wonderful gift from GSA to all of us. And I would love to see all the different groups, networking groups, having some GSA toolkit champion appointed, and keep looking to development and keep connecting to the current work group with the tool, and keep that communication and seeing approaches that we can expand and keep working towards the development of the tool in all these different areas. So I think we all should support and adopt the tool as part of our professional involvement and growth. And I think that will be a wonderful way for us to see that this movement really being able to achieve the goals that has been the vision since its start.
That's great to hear, Patricia. Yeah, I hope the vision goes well. Speaking of the toolkit there, thanks, Susan. She's just put her question in the chat. Susan has a question about medical providers. So can they earn continuing medical education hours as they go through the toolkit training videos and materials?
So this is something for us to talk to GSA. Katie, you will have something to add?
Yes, I think that's one good idea. And I think that the idea of trying to either, well, GSA obviously can't develop these tools for another community, for many of the diverse communities, but for us to link in the toolkit to available tools. So that there are, we tried and we have Spanish language materials, but that's not even close to enough. And I think that there's a lot of interest. So I appreciate those ideas.
And Katie, do you remember when we designed a symposium with the American Congress of Rehabilitation Medicine about the tool? And
Yes.
that was like continuing education. So for the professionals from the society who attended, they got the credits because the society was given. And we talk about, and this is still one of the areas of the tool, to integrate the tool to our different societies because we are so interdisciplinary. So it will be also wonderful that we bring the tool into our different fields and make it available and do a presentation and advocate and champion for the tool. And through those different societies, they could generate like those continuing education credits as well. And GSA is very open for that. They will support you. They have the materials. Katie is always the first one to really help us in doing that. That's how I ended up being really involved with the tool, was promoting to different societies.
It's
Thanks.
exciting.
Yes, great to hear about different possibilities that might be on the table. Thanks, Jordan, for putting your publication in there. I just want to bring everyone's attention to that. It's a 2013 publication, so that's great to see. Comment from Patricia Slatum. She says she agrees with the importance of investing in the community and building relationships, and that being present matters and needs to be part of the research process. Longer term partnership with the community goes beyond each individual research project. So great insights, Patricia. Thank you. Similar from Lisa. She says, thank you. Very fascinating. She's learned similar lessons and has developed a virtually identical approach in her work in rural Florida. Oh, that's great to hear, Lisa. I just want to say that Ying Ma, I'm not to put you on the spot, but I noticed you started typing a question in there and it didn't quite come through. So here's your opportunity if you wanted to pop it in the chat or just unmute yourself if you feel comfortable doing that, because I don't want to leave your question unanswered if you had one. And that goes for the rest of you. If anyone has any questions, here's your chance as we're getting close to the end of the hour.
I could just add one thing about when I was talking to Jordan some weeks ago, I was trying to respond to a request for information from the National Institutes of Health, and they want a way to find people to be involved in clinical trials, people from Indigenous communities, underserved communities. That's what they want. And the request for information said, we know this is going to cost more, and we know that it's going to take time, more time than a regular proposal. So I think that there's realization of that, maybe not total realization of why does it take so much time. And I think that that's a good thing for anyone listening to this to try to teach. Jordan explained it to me, and I think it's so important, and that the trust is a major issue.
Thanks for stating it that way, Katie. Any last comments that you'd like to make, Jordan or Patricia? Maybe we'll start with you, Jordan, as we close things off here.
I'm just really glad that this conversations happened. I think these are important conversations for people to think about, planting these seeds. The importance of engaging communities in any area of work, I think, is important, and kind of these lessons we've shared, the experiences we've shared go across different projects, and really excited to see GSA having these kind of events. I think is really exciting. Yeah, and feel free to reach out to any of us. I think, we have a wealth of resources. We'd be happy to talk more, share anything, or if you just want to talk about what you're trying to do with community engagement, would love to share things we've done well, but also things that I've learned from that didn't go so well. But yeah, it's an honor to be here. Thank you everyone for your great questions as well.
Thanks, Jordan. Great last words. Ying, thank you for your comment in the chat. Ying's a PhD student and is hoping to use this methodology. So you have folks you can draw on here, Ying. Patricia, anything you'd like to end with?
Yes, I was responding to one of the questions. So
Excellent.
it has been some, questions about the definition of, who are the stakeholders and community, especially like when you are developing a tool. So as Katie mentioned, like the tool started 2014, 2015. At that time, the concern, the target population was that many of the care partners, professionals, they were not trained to evaluate brain health and to talk about. So it was really to supply that urgent need that the group that was science was coming, was new, and many through their professional training did not got that type of training. And so it was like a loop to supply the training, the knowledge that was missing and was really bringing so much challenges for us to keep the care. But as I mentioned, everything is informed by research. And so the beauty is that we grow and we learn. There's always more room to grow and learn. So I think there's so many potentials for us to keep developing the tool and the implementation and working with GSA. There has been funding involved and interest of funding. I haven't seen the tool in some of the study sections that I participate. So I think definitely there is so many opportunities, and I think now is the right time for us to look at all the factors, as I mentioned, probably those social determinants of health, how we can adjust the tool to suit some of those very key important areas that usually they are not taking into consideration those tool development. And Katie, again, I'm so grateful for all your devotion to this tool. I love this tool, and so I don't want to speak for you. You are really the mover and shaker of this initiative. So please contribute as you feel.
So much.
Yeah, thank you, Katie. It's great that we were able to be a part of this. Patricia, lovely sentiments. This idea of continuing to learn and grow. I think it echoes what Jordan was saying about planting seeds and important ideas when we think of reaching out to the communities we serve, that we live in, and when we think about things like dementia prevention. And kind of along that line of thinking, Daniel has just put in the chat to thank everyone for the feedback. And if you have any questions or ideas, that we're going to be exploring more of these in our next webinar, which is on June 13th, low income context. Please email Daniel. Oh, thanks, Dan. You've got that up there. Any last words that you want to say, Daniel, as we sign off here?
Just really thank you everyone to join us. We hope to learn with you, and we are learning with you. So yeah, thank you moderators and panelists for this wonderful presentation. Looking forward to more fruitful discussion.
Great. Thank you, everybody. Have a great day.
Thank you for having me. Thank you so much. Bye.